Okay. All right. Hello and welcome. My name is Ryan Tappy and I work with the ALS Association. Thank you for joining us for another installment of our Living with ALS webinar series. The title of today's webinar is Living Well with ALS: How Palliative Care Can Help to support people facing ALS. There are a few things we want you to know before we begin. First off, please know that you are muted and not on camera, so you can relax and enjoy the presentation. There will be time at the end of this webinar to answer questions. You should see a chat box feature on your screen as well as a Q&A feature. You can use either of these options to submit questions you may have. All messages submitted will only be viewable by the hosts and panelists. We will review and answer these questions with our speaker at the end of the webinar. We do have a very short survey we are asking that everyone complete after the webinar. The survey will appear in your browser once the webinar ends. This survey helps us to know your thoughts on this webinar and topics you would like us to consider in the future. Lastly, this webinar is being recorded and will be available on our website in the Care Services webinar page within a week or so. We are so excited to be joined today by Dr. Kara Bischoff. Dr. Bischoff is an Associate Division Chief for Outpatient Palliative Care and the Medical Director of the Outpatient Palliative Care Service at the University of California, San Francisco. Dr. Bischoff has developed a particular expertise in palliative care for people with ALS. She has published substantially about outpatient palliative care for people with illness other than cancer and was recognized as an emerging leader in palliative medicine by the American Association of Hospice and Palliative Medicine. Dr. Bischoff received her medical degree from Harvard Medical School, followed by a residency and chief residency at UCSF in internal medicine and a fellowship in hospice and palliative medicine, also at UCSF. She is an active member of the American Academy of Hospice and Palliative Medicine and the International Neuropalliative Care Society. She is a mother, an outdoor enthusiast, and a San Francisco Bay Area native. Joining Dr. Bischoff today is Diana Cummings. Diana's son, Eric, was diagnosed with ALS in December of 2022. Unfortunately, Eric passed away on March 11th of this year. Diana has graciously joined us today to share her experiences with palliative care during her son's journey with ALS. So without further ado, I will hand it over to Dr. Bischoff and Diana, and I will hop back on to facilitate the Q&A afterwards.
Thank you so much for the kind introduction, Ryan, and thank you to everybody for your time and attention today. As a matter of disclosures, I wanted to mention that I have some grant funding from the ALS Association to study palliative care for ALS. And I also wanted to acknowledge that this talk was put together with my colleague, Dr. Ambereen Mehta, who's at Johns Hopkins, and she was not able to be here today as she actually had a baby on Saturday. So I'm thinking of her and also grateful for the Palliative Care for ALS Working Group. So first of all, what is palliative care? In a phrase, it is care focused on improving quality of life for people living with a serious illness. And I want to emphasize that palliative care can be provided alongside life-prolonging treatments and care, including ALS care, at any stage of a serious illness. So in this way, it's different than hospice care. It's not care only provided at the end of life. It's care that can be provided even from the time of diagnosis. And sometimes I describe that palliative care can be thought of as three buckets. First, through palliative care, we address symptoms. This can be physical symptoms like pain, shortness of breath, difficulty sleeping, fatigue, nausea, etc., as well as mood symptoms like depression and anxiety, which can be so common in the face of a serious illness. The second big bucket of what we address in palliative care is care planning, making sure people have the information they want and need about their illness and what can be expected in the future, and feel supported to make decisions about their care. And the third bucket is broadly described as support for both people living with the illness and their loved ones. We really understand that a serious illness can affect everyone in the family in different ways, and in palliative care, we're therefore very much the locus of care is the whole family. So palliative care is generally provided by a multidisciplinary team. These teams can vary somewhat from center to center, but generally include a provider like a physician, nurse practitioner, or physician's assistant, and a nurse, social worker, and spiritual care provider, as well as administrative members of the team. And it really is team-based care, realizing that a serious illness affects us in medical ways, as well as psychosocial, practical, spiritual, and existential ways. And so palliative care aims to address all of those sources of distress with a team. Palliative care brings dedicated attention to complex symptoms so that this isn't altogether different from what the ALS team, but it's sort of additional time and staffing to help address these symptoms and provide support, again, to people with the illness and their family members. Palliative care physicians also have advanced training in serious illness communication, can sometimes make sure that people have the time and the space to really understand the illness, get their questions asked and answered, and think with a team about what's most important to them. What are they worried about as they look to the future, and therefore what care decisions make sense for them? Palliative care teams can also add some bandwidth to help with care coordination, which I realize can be a very complex, burdensome process in our healthcare system, and provide transition to an end-of-life care, including through hospice. There are multiple benefits of palliative care that have been demonstrated for people with ALS as well as many other serious illnesses. For example, palliative care has been shown to help people live better, meaning live more comfortably with fewer symptoms and improved quality of life. And in some patient populations, palliative care has also been shown to help people live longer, which is a little bit surprising to many people. But it turns out if you're more comfortable, if you're better, more supported, this can translate into living longer as well. As I mentioned, palliative care adds dedicated time and space to address symptoms, whether they're physical or mood symptoms, address sources of distress, provide support to help people have the best quality of life possible in the face of illness, and ensure that treatments are consistent with what matters most to people, people's values and priorities, and to help coordinate care. So to provide a case, Mr. R is a 59-year-old man who loves to run. One day he had a near fall while running, and then he went on to develop low back pain that persisted. He didn't think much of it, but over months he began to feel less stable on his feet and he was no longer able to run. He had an evaluation with a spine specialist 6 months later and was treated with anti-inflammatory injections in his low back. These helped with his pain, but unfortunately his weakness continued to progress. He was referred to see neurology about 1 year after his first fall, and in addition to his limb weakness, the neurologist noticed that he had lost weight, it took him longer to chew and swallow, and he had mild shortness of breath at night with associated anxiety. At that appointment, he was diagnosed with limb onset ALS. So this is quite a common story, the long trajectory to get the diagnosis of ALS. And often by the time people receive a diagnosis of ALS, they already have needs in multiple domains. I'm sure I don't need to say too much about this to this group. I'm sure you're aware that there can be a large number of symptoms. There can be communication challenges. The protracted and stepwise decline associated with the illness is very difficult. There's uncertainty about the future. People with ALS face complex decisions about their care and have high caregiving needs. So given all of these needs, palliative care can help in a number of ways by alleviating symptoms and improving comfort, enhancing emotional and psychological well-being, facilitating communication amongst members of the healthcare team and the patient and family, and assisting with decision-making, and supporting people with the illness and their families throughout the journey. So truth or myth? Patients must stop seeing their ALS team if they're receiving palliative care. I realize based on the webinar format today, I can't see and hear you, but I'm going to give you just a moment to think about this, test your understanding. And this is, in fact, a myth. In fact, people with ALS don't have to stop seeing their ALS team if they're receiving palliative care. Palliative care can be provided alongside ALS care, even from the time of diagnosis. Another truth or myth to test for understanding: patients cannot continue ALS treatments when receiving palliative care. I'll give you a moment to think about this. Truth, myth, or unsure? And this is also a myth. Patients can, in fact, receive ALS treatments and other life-prolonging care, like going to the hospital, even the intensive care unit, being on life support, having a tracheostomy placed. All of those types of life-prolonging treatments can be consistent with palliative care, can be provided alongside palliative care, as long as they're consistent with the person's values and priorities. So importantly, palliative care is not strictly comfort care. It's not only for people who want to prioritize their comfort over life prolongation necessarily. In fact, there's a couple different models of care. The sort of older model was to see disease-directed care, in this case, ALS care, as coming first, and then having palliative care ramp up near the end of life as people transition to hospice care. But in the new model of care, disease-directed or ALS care should be provided alongside palliative care from the time of diagnosis, with palliative care ramping up gradually over time, and then transitioning to not just hospice care, but also bereavement care after a death. So to continue our case, Mr. R continued to struggle with his breathing and associated anxiety. He started BiPAP, a form of breathing support that helped his breathing and energy significantly. He saw a palliative care team, and low-dose opioids, as needed, were added for severe episodes of shortness of breath when the BiPAP wasn't sufficient to provide comfort. The palliative care team also talked with him about his anxiety, and anti-anxiety medicines were started. He also met with the palliative care social worker for counseling. The social worker met with a family member as well for support around adjusting to the caregiving role. So here I just want to highlight that palliative care teams can help with symptoms with medications, as well as non-pharmaceutical interventions like talk therapy, support, and counseling for family members, connecting them with community resources, etc. By a year and a half after his fall, he was losing weight, and his ALS team recommended a feeding tube. But even after meeting with the ALS team and having that conversation, he felt profoundly unsure about whether that was the right decision for him. So this is another way that the palliative care team can come in and help in ALS. There's a lot of complex decisions that people with ALS may face along the way. Questions about whether to have a feeding tube placed, for example, whether or not to initiate invasive or endotracheal ventilation through a tracheostomy, whether or not to be resuscitated should their heart stop or not pump blood effectively, and how to address communication challenges. So advanced care planning in ALS is the second big bucket that I described that palliative care addresses. And one of the questions that we very commonly ask people is, as you look to the future, what are you hoping for? And the paired question, again, as you look to the future, what are you worried about? I think this pair of questions is really important to make sure that everyone in the healthcare team really understands this person with the illness, what matters most to them, and can help make it possible to live in the ways that they want to as much as possible in the face of the illness. Another common question that we ask people is, if you weren't able to make or communicate your own healthcare decisions, is there someone who you would trust to speak on your behalf? This is essentially designating a durable power of attorney for healthcare, or DPOA, also called a surrogate decision maker. And this is really important to understand because if no one is named, decisions are typically deferred to a default surrogate, which might work for some people. That's typically, there's in each state, there's a different hierarchy of who is the default surrogate. And there's some states that don't have a default surrogate or a default hierarchy, and therefore the healthcare team sort of looks to the people who are closest to the patient and seem to have their best interests at heart. But it's without legally designating who you'd want to make decisions for you, the healthcare team will ask others, and that might be appropriate, but it also might lead to someone other than who you'd like to make decisions on your behalf. A durable power of attorney for healthcare can be legally designated in an advance directive document, and this can be completed by the palliative care team. It doesn't have to be completed by an attorney, not something you have to pay to get done. The advance directive designates a surrogate and gives you the opportunity to state preferences around end-of-life care, what kind of care you would want or not want if you are seriously ill. And I want to emphasize that this can be updated at any time. And it's different from a POST form or physician's order for life-sustaining treatment form that you may have heard of as well. The POST form indicates current preferences for medical care. It's actually an order that emergency medical people have to honor, whereas an advance directive talks about your wishes for future medical care. There's an interactive website called prepareforyourcare.org that's a really nice tool to use to sort of step through each aspect of creating an advance directive, and it generates an advance directive at the end. So if you're looking to engage in some advanced care planning independently, and even before meeting with your team, I would recommend this resource. Another way that palliative care teams often address and engage people in advanced care planning in ALS is to provide more information about the treatment options they may face, like a feeding tube, a ventilator, resuscitation, whether to return to the hospital. And palliative care teams strive to make recommendations to people who are feeling really ambivalent that are rooted and based in that person's values and priorities. And they allow a little bit of additional time to explore options above and beyond what might come from the ALS team. So here too, I want to emphasize that palliative care for people with ALS is not altogether different from the care that's provided by the ALS team, but it's sort of extra time, bandwidth, and opportunity to have these conversations in a safe space and get additional support or a different perspective on matters. It's also, palliative care teams also can help people consider whether and when a transition to hospice is appropriate. So just to talk a little bit about hospice care in ALS and how this is distinct from palliative care. Hospice is a program and it's an insurance benefit, and it's appropriate for people with a prognosis of 6 months or less. So that's distinct from palliative care, which is not prognosis dependent. It can be for any person living with a serious illness, even from the time of diagnosis. Additionally, for hospice care, the focus is on comfort and not on life prolongation. So unfortunately, in hospice care, based on the restrictions of the insurance benefit, they cannot provide life prolonging care, can only provide care aimed at improving comfort. So when is it time for hospice? Certainly when prognosis is short, you have to have this prognosis of 6 months or less. And some of the things that doctors think about when determining whether the prognosis is that short or not is the degree of respiratory weakness, the amount of weight loss, whether there have been other life-threatening complications such as hospitalizations for severe infections, and people need to really prefer a focus on comfort and staying in place. Typically that's at home, not returning to the hospital unless comfort can't be maintained at home. So another question for you, and make sure you're still with me and awake. Truth or myth? People cannot continue ALS medications in hospice. This is generally true. As I mentioned a minute ago, life-prolonging treatments are not consistent with a hospice plan of care, so that's distinct from palliative care. Generally in hospice, medications are provided for comfort and not for extending life. So ALS medications like Radicava typically are not provided when people are on hospice. So what to expect with hospice? Certainly attentive symptom management, easier access to symptom management medications, some medical supplies and equipment. So the hospice team often can have meds delivered straight to the home. They can have an easier access to a hospital bed, for example, bedside commode, oxygen, things that might be helpful for comfort. They do home visits and have a team on call 24/7. So if something comes up after hours, you can call the hospice team and reach a nurse on call. They generally will provide tube feeds and BiPAP, a form of respiratory support for people with ALS. They provide a lot of support to care partners with more frequent touch points at home than other medical teams can typically provide. And the hospice service, or the hospice benefit, comes with advantage of grief support for up to a year after a death. But I think it's also important to realize what's not typically included with hospice care. For example, members of the hospice team don't typically provide hours of care at the bedside. They don't come and stay for 8, 12, or 24 hours a day at home. They come for brief intermittent visits. So the nurse from the hospice team might come for an hour or two once or twice a week, for example, but they don't stay and provide that direct care that may be needed and multiple hours a day. There's still the expectation that that's provided by family or hired caregivers. Generally, hospice teams don't provide medications for ALS that are aimed at prolonging life, like Radicava. They generally don't do blood work or imaging. So if a person on hospice, for example, had a fever and a cough, and there was a suspicion that they might have an infection in their lungs, typically the hospice team would assess that clinically by listening to their lungs, by hearing about their symptoms, and would make a decision about whether to treat for pneumonia, for example, at home, rather than sending the person to the hospital for workup, such as blood work or imaging. Hospice teams also don't typically provide rehab services like physical therapy or occupational therapy, because again, the focus of hospice is comfort, not necessarily getting better or stronger, which rehab services can offer. This is a highly controversial point, and I think it would be ideal if hospice teams could offer this, but it's not currently included in the hospice benefit. They also have a limited budget. Hospice is provided on a per diem rate, and so they can't cover really expensive equipment like power wheelchairs, speech generating devices, non-invasive ventilators like a Trilogy machine. So for people with ALS, we try to think about whether these are needed and have people obtain them before they transition to hospice. Hospice care also doesn't typically come with hospital care. Generally, the hospice team tries to care for people in their homes, except when hospitalization is needed to control symptoms. Truth or myth, people must change their code status to DNR to enroll in hospice. So code status refers to one's resuscitation preferences. If their heart were to stop, would they want an attempt at resuscitation? This is actually a myth. Some people feel very strongly that they don't want to be a DNR, that they want to have an attempt at resuscitation when their heart stops. And people with that preference can still enroll in hospice. Truth or myth, all people move into a hospice facility when they enroll. This is a myth. As I mentioned, actually, most people receive hospice at home. And that's where the large majority of hospice care occurs, including for people with ALS. Occasionally, hospice care can be provided in a nursing home, in an assisted living, or in a residential hospice facility, but this is much less common. And one of the major tenets of hospice care is to bring the care to where people prefer to be, which for most people is at home. So before I transition, I wanted to the next portion of our talk, I wanted to mention that there's a number of different resources online about palliative care for people with ALS, and I welcome you to check these out if you're interested. For example, from the ALS Association website, here's 10 things to know about palliative care. how to get palliative care if you're interested in this service. In short, palliative care is a medical specialty, just like cardiology, for example, and neurology. It does require a doctor's referral to have palliative care covered by your insurance. So you can ask your doctor, whether that's your ALS physician or your primary care doctor, for a referral to palliative care. This, again, as a medical specialty, is covered by most insurance plans. And palliative care can generally be delivered in clinic, sometimes in the home, and increasingly by video. Certainly since the COVID-19 pandemic, we've all been using video visits more and more. And I think particularly for people with ALS and their family members, we've found that people really prefer and appreciate being able to receive palliative care this way because of the burdens of getting to clinic. Palliative care is also offered in the hospital, but hopefully those of you on this webinar are not in the hospital. But if you find yourself in that setting, it is also reasonable to request palliative care there. The visit frequency for palliative care typically matches the needs. So if one is relatively stable, you might be seen by your palliative care doctor every month or 2 or 3. But if needs increase, if you're having a lot of physical or emotional symptoms, if you're struggling to make a decision about your care, or if your care partner needs more support, for example, the visit frequency might be able to increase. So thank you so much again for your time and attention. I put my email address here because I would really welcome you to reach out to me by email as well as through questions in the chat. But we're going to spend the next 15 minutes talking about Diana's story. So I'm going to escape out of here so that hopefully you can focus more on Diana's face. But as Ryan mentioned, Diana is the mother of one of my extraordinary patients, young patient, Eric Cummings, who I had the pleasure to get to know through his illness journey. And I'm so grateful, Diana, that you've joined me here, really in the fairly recent wake of Eric's death, to share a little bit about your experience, both with care and broadly speaking, and with palliative care specifically. So I was wondering if you could just start by telling us a little bit about Eric and your journey and his journey with ALS.
Yeah, thank you. Yeah, Eric he was 37, he was 35 when he was diagnosed. Super active, super outdoorsy person. It took, like many, it took, some time to get diagnosed. Um, and then we got referred to UCSF to the ALS what did they call it? The multiple disciplinary or whatever team. And they were we were really fortunate to be with UCSF. And we started going I think it was every 3 months we would go. And so each visit we went, they did all the assessments and everything. And then, do you want me to speak more specifically to the palliative part of it, right?
Yeah, so that was the
Yeah.
next question I was going to ask. If you'd like to speak about the palliative care that
Yeah.
your family received, I'd be
Yeah,
happy to
so
help.
it was great. Like you kind of don't know what you don't know. And so sometimes I didn't even know like what questions to ask, but the ALS team at UCSF and then the palliative team at UCSF work so closely together that I do remember being told about palliative care kind of early on in Eric's after Eric's diagnosis, but completely didn't understand like what it was for, how did what did it mean to be, and so we were told about it, and then we got connected with you, Dr. Bischoff, and then I just found I had a lot of questions, and so it was so helpful to have this extra team of people supporting us. We would go to clinic every 3 months. And then like in between those visits, we would meet with Dr. Bischoff and her team. And we had, I think, one in-person visit, but then the others we did maybe one or two, but we did over video. And so we got to meet her team, her and the nurse, and then the spiritual counselor. Um, and so for us, it was just so nice to have like an expanded team of support. Um, because I don't know about anybody else that's watching or that's dealing with ALS and how you feel, but we kind of felt like we heard, this is such a, well, before diagnosis, heard it's so rare. And so then you have this disease that's so rare. What does all that mean? And there's just a lot of questions, a lot of fear. Um, and I just felt like the two teams work so good together. They really, the ALS clinic team and the ALS palliative care team work so good together that it wasn't like we had to retell our stories to each one, which was really, really helpful. Because when you're going through medical stuff, you tend to have to go through your story, a lot of different times because you're talking to many different people. So I found that was another thing that was really helpful. Dr. Bishop had talked to Dr. Goslinga talked to Dr. Bishop and the team, and then it just felt so nice to be so well supported. Um, and it was just a huge gift to us to have. And we found that everybody that we talked to was just so good at what they did. So they asked all those questions that Dr. Bishop's just, or not questions, but all those points that Dr. Bishop mentioned as far as like the 3 bucket list, the symptoms, the care planning, the support. We experienced all of those in different ways. Many times we'd be on a call and then Dr. Bishop would start asking these questions, and I'm like, oh gosh, I'm so glad you asked that. Was not sure, like sometimes you don't even know what questions to ask, or you're feeling something, whether it's a physical thing or an emotional thing. You kind of don't. It's just an kind of an unknown journey for I think for all of us that are walking this path. And so it was really helpful to have somebody who has so much experience. And then we also felt so cared for. The empathy that we felt as a family was just so, and I'm going to get emotional talking about it, but I'm so thankful for it. Dr. Bishop, all of the doctors, so Dr. Goslinga was our ALS team, Dr. Bishop was on our palliative team, and both were so empathetic to us. So I found like you're not like my stereotypical um, perception of a doctor. I found that they were just so caring. And, we had, as most families do, it doesn't just affect the person going through it, it affects each family member. And I really felt like, they asked about, well, so how are you doing, Diana? Wow, somebody's asking about me. How's Kevin doing? It's Eric's dad. Wow, somebody's caring about that. So I found it so helpful. And then they also have the spiritual care counselors. Um, I I I made an appointment a few times and found that to be really helpful because it was just me. And but they offered it to all of our family, and we could make individual appointments with the spiritual care counselor. And I found it to be really helpful because it's just somebody who's dedicated to you, listening to what you're going through personally, because it's going to be different from for each of us. If you're the patient, you've got a different experience than if you're a caregiver or a parent or a sibling or any family member. So I found that really helpful as well. Um, yeah, I just overall, I just felt a huge amount of support from both teams, and so it was super helpful.
I'm so glad. Thank you for sharing about your experience. And do you mind saying a little bit more about how you found palliative care or how you might
Yeah,
recommend other families find
yeah.
palliative care?
So, I mean, we were really fortunate to be cared for by the UCSF team, and I think for us, they actually told us about it. Like I remember Dr. Goslinga talking about it, and she was our ALS doctor. Um, and just kind of going, yeah, okay. I just, like I said, I didn't really know what it was. And I remember talking to you, Dr. Bishop was like, what is the, what is the role of palliative care? And asking those questions, like, and I still didn't, it was like, you don't get those answers in one visit. It was over time, right? That you really learn the value of it. But I heard about it initially from, I believe, from Dr. Goslinga. And then my memory's kind of a little bit of a blur right now, but I know that there was a referral to you about getting the palliative care team on board, and we got it on the earlier, well, I don't know. To me, it felt like on the earlier side because my perception of palliative care, I didn't know much about palliative care, but I always thought it was like the very end of life. Like I was really confused about what palliative care and what hospice care was. So getting on it really early, I got to experience what it was like. And so getting on it early was really, really helpful because I just felt like we would meet in between the visits. And so I think yeah, so we heard about it initially from our ALS team and then just got connected with you and then Dr. Bishop I believe reached out to us and then we just got an appointment on the schedule and so that's how it kind of started. And then we met with Dr. Bishop, the nurse, and then the I think the spiritual counselor was on the call at the same time, kind of like this, to make initial introductions. And then I know super helpful to see the team and kind of have them introduce themselves to us and then us to them and learn more about our family. And yeah, so that's kind of how we got connected, is from what I remember anyway.
Thank you for sharing. And you mentioned hospice, that came in later in
Mhm.
the illness experience. And do you
Yeah.
mind just commenting on the transition to
Mhm.
hospice and how that care was different
Mhm.
or similar from the care types of care you'd received previously?
Yeah, yeah. So um, it was all scary. Um, but I gotta tell you, the support I felt was huge. So we were at the appointment with Dr. Gosling doing our regular clinical visit, and then they had brought it up at that visit that he was, based on the symptoms and everything, he would be basically eligible for hospice, and we anticipated that conversation coming up at some point. Um, and we had had a hospital visit with him shortly before that visit where he was struggling, had gotten sick and had a virus. And so he had spent some days in the hospital. Um, and that was scary. And then, um, and then we went through the assessment to find out like where he was at with all his numbers. And when then they brought the whole subject of hospice up and they did it so gently, so kindly. Um, we kind of knew it was coming, but when it comes, you're never really ready for it. Um, and then I know I was like, I just had so many questions about like, well, now what? Now what? Now what? And I'll never forget because my biggest concern was keeping Eric comfortable. Because we weren't able to keep him comfortable. That's why we ended up in ER. And so I'll never forget getting a call in the evening from Dr. Bischoff and just kind of walked me off the cliff. Like, how do I had a lot of questions and I was scared and it was just kind of, dealing with just the whole emotional part of going on hospice. And so it seemed kind of like it just sort of happened. And so like it's so valuable to have a phone call from Dr. Bischoff and so here, I can help you with this. So she was able to kind of do that. And I don't need to go into details, but it was like it helped so much because I could just ask my questions. She could help me with what was my biggest concern. And then then we started getting phone calls from the hospice team. And then shifting over to hospice, we got another huge team. So we had, we had the nurse that came, she came twice a week. We had a social worker that came I think every couple weeks. We had like a spiritual care counselor on that team as well. And they came as much as we wanted them to come. But they didn't just come and say, "Oh, hi, how are you?" Each person came, spent like an hour with us, got to know our family, got to really know us. And the palliative care team did that too, and we'd be on the phone calls. And then so and then I was kind of wanting to keep so so for our situation, I don't know if every situation could be this way, but Dr. Bishop stayed on our team because I think we were allowed like one doctor to be our main doctor. And so we requested Dr. Bischoff and she accepted. Um, and so that coordination actually worked really well between the two. And then when we got on the hospice team, hospice was wonderful to work with. Again, it was just that added support. We had hired some caregivers outside of all of the other care that was provided, but just to get that bigger team to address our questions, our concerns, our fears, and then ask the questions that we didn't even know to ask. And just having their experience just really, we found to be really, really helpful. And they were just also kind. Like you could tell they were good at what they did. We felt really cared for. We didn't feel alone. I had a phone number, like being on hospice, they give you a phone number. You can call that phone number and ask so many different questions. It was hard experience, obviously, but we didn't ever felt alone. And for me, that was really, really helpful.
You so much, Diana. I want to leave plenty of time for questions from the chat, so maybe this is a good time to hand it over to Ryan if you want to
Yes. Yes,
get to any
absolutely.
questions from the
Thank you.
chat.
Yes, thank you for the great presentation. And Diana, thank you for sharing it. It really sounds like having that connection with your palliative team helped with some of those transitions into other forms of care like hospice, as you mentioned. So I so
Mhm.
appreciate you sharing. We do have a few questions that I want to make sure we do have time for. And I'm just going to go in order from which I received them. So the first one was that the palliative care sounds like a fantastic addition to the life of a person living with ALS. And they were just curious, are there any drawbacks that they need to consider when they're having these conversations about palliative care?
You want to address that, Diana? Did you feel like there are
Yeah.
drawbacks that are important for people doing that?
No. So yeah, I that's a great question. I only found benefits to palliative care. Nothing was taken away from us with palliative care. So we could still get different things. I mean, like, if you're just talking about insurance, that's one side of it, right? Like, will insurance cover these different things on palliative care? Everything was covered like it was regularly as far as needing certain things. I didn't feel any takeaways or any disadvantages of being palliative care. I only felt benefits from it because it was added people, added resources. The palliative care team has so many great resources. And they, like I said, they just asked us questions about things we didn't even think about. So I didn't see any disadvantage of it or any takeaways. We didn't lose anything. We still had our ALS team. We still had all our needs met.
Thanks
I
for
worked it
sharing
was
that.
bad.
And I'm really glad to hear that was the case. And I think, perhaps the one thing to mention is it's more cooks in the kitchen. It's more people to meet with. So if that seems like you're already on overwhelm and you can't imagine having another visit, perhaps that's one thing to keep in mind. But I would hope that the palliative care and ALS clinicians would work together so you wouldn't have to repeat your story and that they would coordinate care between themselves to not add more care coordination challenges to your plate.
And kind of going off that question, and this could be a question for Diana with your experience or Kara with what you know about palliative care. Somebody asked, does palliative care include any extra care into the home, any caregivers?
Right. So generally, palliative care does not provide direct hands-on care in the home. Unfortunately, that would be terrific. I think there's a lot of advocacy efforts going on trying to make our programs more robust so that covered services could include more of that direct hands-on care. But at the moment, there isn't much in terms of direct hands-on care that's provided by palliative care teams. There are home-based palliative care teams that'll visit people in the home, but they're still having more of a discrete medical visit rather than providing that hands-on care hour to hour.
Great, great. Another question from somebody who mentioned that they were recently diagnosed and that each day with ALS is so unpredictable. So, with the unpredictable nature of ALS, does that affect how the palliative care is provided, or is that kind of nixed with all these ongoing collaborative conversations that you both mentioned?
Yeah, really good point. That things can change so significantly, from week to week, certainly from month to month. And we just try to meet people where they're at, try to understand what are the most pressing challenges, concerns, questions on their mind at this moment in time. How can we go there and help with that issue, realizing that it might be something totally different next time? Of course, we're trying to anticipate needs, provide some anticipatory guidance as well. But oftentimes, there is this feeling we're walking with people through this unpredictable trajectory and trying to just assist them in the ways we can today to make things a little bit easier and make things a little less terrible. And so there is a wide range of what we talk about in our visits. Might be a physical symptom one day, might be an emotional need another visit, it might be a practical concern, might be more about the caregiver's needs the next time. And that's partially why we have a robust interdisciplinary team on the palliative care team, is we realize that the needs may be medical, they may be more psychosocial, they may be spiritual or existential, from one visit to the next.
Great, great. And is palliative care something that's typically covered under insurance? This specific question was referencing Medicare.
Yes,
Okay.
palliative care is covered by Medicare. There are some Medicaid plans, we call it Medi-Cal in California, but Medicaid plans that have restrictions on where palliative care can be received. For example, has to be received within one's county. So there can be some restrictions in where you receive palliative care, but in general, palliative care is, like other medical specialties, a covered benefit.
Great, great. And in your experience, both of you, how long does it typically take from the referral to the start of services? Is that something that happens pretty quickly?
Yeah, it's going to vary from program to program, but in our program, it's usually 2 to 4 weeks, depending on sort of how long our wait list is. But we certainly try to get people in as quickly as possible, realizing that when someone has a serious illness, there can be some really pressing needs, and we need to meet people as quickly as possible to understand those needs, and then we can schedule follow-up visits as needed. Sometimes it's more frequent, sometimes it's less frequent.
Sure.
Can
No,
I
Diana,
add
if that sounds consistent to you, yeah.
Yeah, can I add something to that? I think
Yep.
that's the benefit of entering palliative care earlier too.
Mm.
Like like because I didn't feel that waiting period. So like we entered it like I felt like we entered it kind of on the earlier side because it was like, well, I don't really know what this is, but let's go ahead and try it out. So I think there's a benefit to actually if you can bring it up with your ALS team, ask about palliative care. Um, because then the wait's not going to seem so long if there is a wait. Like I didn't personally experience a wait. There probably was that I just wasn't aware of, probably because we entered it sooner than later, so that when you really want it or you really want more support, it's there. Because it was beautiful for us uh, because I think we started a little bit, well, it felt early to me, but
Sure. Okay. And then someone who's asking for some clarification, and this could be from both of you, from the personal experience, from the professional experience, in how the services that palliative care offered differed from the services that they're receiving at the ALS clinic. I know you guys both mentioned that there's a collaborative feel between the clinics and the palliative care team. But are there any specifics of how those two care providers differ?
Yeah, It's a great question. I realize that this is confusing. There is a lot of overlap in what palliative care clinicians do for people with ALS and their families and what ALS clinicians do. I think certainly the ALS team has more of a focus on monitoring the disease, seeing how it progresses over time, and counseling people about and prescribing ALS disease-modifying treatments like Riluzole, Radicava, maybe talking about genetic testing or clinical trial options. All of that is within the purview of the ALS team. Of course, the ALS team also talks about symptoms, whether that's excessive saliva or pain, shortness of breath. The physical therapist and the occupational therapist might talk to people about, moving and accomplishing the activities of daily living, etc. The palliative care doctor, of course, also addresses symptoms, but they have a little bit more bandwidth to focus on the symptoms because they're not focused as much on the disease monitoring and the disease modifying treatments. So their focus is more exclusively on symptoms. So when symptoms are particularly difficult to manage, challenging, severe, I think adding that extra bandwidth of a palliative care team that has a little bit more bandwidth to focus on symptoms can be helpful. And then certainly both teams could talk about what to expect with ALS and provide counseling about treatment options, including potential procedures like a feeding tube or a tracheostomy, for example. And there too, I think the palliative care team can be helpful when there is either a lot of questions or indecision or distress around preparing for the future, making these decisions. So when there is that higher level of distress, indecision, just need for more time and space, a different sort of safe space, different perspective to consider these decisions, I think a palliative care team can be particularly helpful. And then with the emotional support, certainly the ALS team, and it's generally a large multidisciplinary team, they provide emotional support. But sometimes people feel like they need more bandwidth than the ALS team has to offer. They want more counseling, either for patients or for family members around these really intense, feelings they're having or emotional reactions. And there too, I think the palliative care team can add bandwidth. So lots of overlap, some
Yeah.
differences in focus and training and expertise. And certainly the palliative care team adds bandwidth when things are particularly difficult in any of these domains.
And
That's
can I add one more thing about that?
Yeah.
Just as a patient, just because of that bandwidth, there's more availability to get your questions answered as well.
Mhm.
So, like you've got both teams, and yeah, there is overlap on the things that they provide. But just, I mean, we've all experienced, how it's really hard to get an appointment, or I have a question about this. And so when you have a larger team, there's more opportunities to be to cared for because they do, or our experience was, is that they had the bandwidth, they had the time for us to be able to address our concerns in a really good manner, or in a timely manner.
Great, great answers. Okay. I'm keeping an eye on the time here. We just have a couple more questions. One that has popped up a couple times that I'm seeing is whether palliative care is available through the VA. And I'll just add that I believe it is, but the best bet would be to talk with either your VA social worker or physician about that. But Dr. Bischoff, I don't know if you can add anything to that.
Yeah, certainly outpatient palliative care is available at many VAs. I can't promise every, but certainly many VAs have outpatient palliative care outside the hospital as well as inside the hospital. So definitely worth asking if you receive your care at the VA.
Okay. And this will probably be the last question that we have time for. And this is kind of for both of you. For those who haven't explored palliative care, are there suggestions for how to start that process or start the conversations with either the healthcare providers or maybe Diana with family members who maybe are confused? And for Diana, did you have any challenges with those conversations with other family members?
About palliative care specifically,
Palliative or hospice care, sure.
yeah, so I think his family had a lot of conversations together. So I mean, fortunately, we were all kind of on the same page, and so I think we all, you know, well, palliative care was just a mystery to us at first, but just based on from our experience, I just learned so much. Um, and so I don't know if that answered your question or not, but yeah, I felt like we were all ready to. Palliative care was an easy decision because there's no takeaways. Going on to hospice, some things were taken,
Mhm.
some medications aren't covered, equipment changes aren't covered. So there were some takeaways on hospice, but the gain was so much more. So the decision to go to palliative care was an easy one for me and for our family, because we experienced just an added support team and availability to get our questions answered and the symptoms dealt with better.
Great.
Mhm. I think sometimes I've heard patients say, I asked my doctor about getting a referral to palliative care, and they said it's not time for that yet. So I
Mm,
think sometimes people can get that response, and it's based on a common misconception about palliative care being really end of life care, and being more appropriate for people at late stages of the illness. And oftentimes people are conflating palliative care with hospice care. So I think if that happens, just explaining that my understanding is that palliative care is an extra layer of support to improve quality of life for people living with a serious illness. That is certainly our understanding and definition of palliative care. It's not dependent on having particular preferences like preferring comfort over life prolongation or feeling ready to give up any type of care. I think palliative care is really just an extra layer of support to improve quality of life for people living with a serious illness and can be provided throughout the illness. So hopefully with that understanding, doctors would feel more comfortable referring, but we certainly do have a sort of public awareness campaign that's ongoing and needs additional work in palliative care to describe to everyone who we are and what we do. So thank you for
Yes.
your attention, allowing me to do a little bit of that today.
Yes, and thank you for coming. Unfortunately, we are out of time. So again, thank you to our wonderful speakers, Dr. Kara Bischoff and Diana Cummings, for the amazing presentation. Couple of quick reminders. You can view a recording of this webinar on our Care Services webinar page. You can also use that web page to view all of the past webinars that we have recorded, as well as sign up for future webinars that we are hosting. And lastly, a final reminder that you will receive a short survey when we end this webinar. Thank you to everyone who was in attendance today, and thank you again to our great speakers. We hope everyone has a great rest of their day.
Thank you so much. Special
thank
thank
you.
you to Diana. Really
Thank
appreciate
you.
being here.
Thank you.
Thank you both.
Take care.